right, I have 3 o'clock, so we'll go ahead and get started. So this is Betsy, and welcome to the Discharge Meds and Clinical Focus Call. I wanted to apologize for having to change the time this month, but we've started with our VQI at VAM preparations. So I just had to change the time only for this time only. So for our next meeting in April, it'll go back to the 1 p.m. Eastern time. So thank you so much for changing your schedule. I greatly appreciate it. So our agenda today, again, welcome and Happy New Year. I can't believe we're already into 2022. We're going to talk about abstracts, charters, a historical review that I did, the National Quality PSO Long-Term Follow-Up Survey results. We're going to go over that in detail. We're going to discuss our guest speakers that we'll be having in April, and then we'll have time for Q&A. And just as a reminder, as always, your first resource is always Pathways or 5.0 support at psupport@50health.org. And if you ask me a clinical question, I will redirect you to them. We can't always have a clinical SVS PSO staff on our focus calls. Our focus calls are not specific to answer clinical questions. Our calls are specific for networking, charters, quality improvement projects, and general improvements. That doesn't say that you can't ask us a clinical question, but I just wanted to just make sure that you understand, because a lot of you have asked me clinical questions, and that's not my first line. So I just wanted to, first line of defense, or I'm just not your first resource for that. So I just wanted to just remind everybody, just a gentle reminder for everybody. All right, so VQI at VAM 2022, it is already upon us, and it's going to be from June 14th and June 15th this year, and it's actually in Boston. Just wanted to let you know we're calling for abstracts. The abstract submission deadline is February 18th. Notification of acceptance is March 11th. And our poster session is that Tuesday night, June 14th. I already have a couple of poster abstracts so far, and we're looking for more. If you have any questions on that, just email me and let me know. But we're looking forward to having another great poster session again. So charters, I wanted to kind of look back and kind of take a historical review. And so I looked back on quality improvement charters back to 2018. And in 2018, we had 55 charters submitted. 2019, we had 37 submitted. In 2020, we had 58. And last year, we rounded out the year with 69. So congratulations on all of your hard work. I further broke it down into long-term follow-up, discharge meds, documentation, clinical, and other. And you can see those right there on the screen. And other, people are like, hey, what is that? Other could be like a mixture of like discharge meds and clinical together. Could be documentation and discharge meds. So that's what the other category is. And you can see documentation in 2021 had 25. So that was fantastic. Discharge meds were at 12. Clinical was at 15. Long-term follow-up was at 8.
Go on there and give your attention. God save the United States. This honorable court. This honorable court is now in session.
Mute somebody here. Oh, somebody did. Thank you. And also the other category, as I shared, which is a combination of the other 4. There were 9. So I want to say again, congratulations on all of your hard work. Now, I will be doing this annually just to kind of keep up with this. But again, this just shows all of your hard work and dedication to quality. So moving on, maybe. So this is a snapshot of the PSO National Quality Long-Term Follow-Up Survey results. So what we did is we sent a MailChimp survey to everyone that is documented as a hospital manager. And so there were 1,631 people identified as a hospital manager. 613 of the 1,600 opened the email. Of the 600 that opened the email, 356 actually opened the survey. And of the 356 that opened the survey, 135 actually took the survey. So I know that's a lot of numbers thrown out at you. So I just want to let you know the end number was 135. So the survey was open from 12/9 of last year until 1/7 of this year. So we had 11 questions that we asked. And first question was the number of centers that you abstract for. And the majority, or 90 participants, actually said that they abstract for one center. And then you can see all the others. But the majority of people abstract only for one center. The next question was, do you use a third-party abstraction? 23 said yes, and 109 said no. Now, of those 23 that said yes, we wanted to know, if you use the third-party abstraction, are they procedure abstraction only, long-term follow-up abstraction, or both? 9 said procedure only, 0 said long-term follow-up only, 11 said both, procedure and long-term follow-up. So another question that we asked were the registries that centers participated in. And we also talked about if you were like a mother facility with sister hospitals and all of that. Well, the PSO staff, we felt like we didn't word that correctly. And we kind of got some skewed data because we know that our carotid modules registries actually have higher volumes. So we actually decided to throw that question out because we didn't feel like that data was accurate. So moving on, the next question was, how many FTEs do you have allotted for long-time follow-up? And 53 said that they have 1 FTE allotted. 13 said that there were 0 FTEs allotted. And 17 said that there were 2. Now keep in mind, there were 10 that left that question blank. So the next question were, what are the difficulties in collecting long-term follow-up? So lack of dedicated staff for long-term follow-up data collection, 46 said that. 16 said that staff were reassigned due to COVID. 83 said follow-up occurs at an office outside of their facility. 74 said follow-up occurs outside of long-term follow-up window, which is 9 to 21 months. 17 said there was a lack of scheduling resources. 43 said there was a lack of access to medical records. And 17 said other. And we're going to talk about the other in just a little bit. Next, we talked about, talked about patient concerns for long-term follow-up. And the question was, do your patients have any concerns in regards to long-term follow-up? Only 45 said they were concerned about COVID. 36 said financial concerns. 53 said long distance or travel was a concern. 29 patients said that they had no concerns. 41 basically just refused. And then 19 had answered other. And again, that was a free text option. And we'll review that in just a moment also. The next open question that we asked was, do you actually review your long-term follow-up with the leaders in your hospital? 87 said yes, 26 said no, and 20 said other. And that was the last question that we had other, which was also a free text. And again, we will look at that in more detail in just a few minutes. I will say that all 18 regions were represented And the top 3 that responded to the survey were Midwest, New England, and Southeast. So congratulations, but all 18 regions responded. So question 9 is the first question that we're going to discuss with the open-ended question. And that was, does your center have trouble collecting long-term follow-up due to the following? So these are just some of, just some of what was actually typed in. So as you can see through all of these, there's just various answers. There's only 2 of us. We abstract both the procedure, hospitalization, and long-term follow-up. They felt that the long-term follow-up form is too detailed and it asks for too much information. Someone else, doctors don't complete the necessary paperwork. Patient non-compliant. There's no trouble collecting long-term follow-up at this time. And that one was actually said probably about 5 or 6 times that in reading through everything. Lack of documentation or manpower. Patients cancel all of their follow-up appointments. Something that we also noted that was actually typed in. Carotid cases will not warrant a 1-year follow-up per the surgeon if post-op course was uneventful and does not require subsequent follow-ups following the initial one. Also, surgeons are more interested in the 30-day follow-up than an annual follow-up. Than an annual follow-up. Also, follow-up documentation does not always address all required fields, and fields do not have an unknown option. So you can see there was basically a variety of free texting in that. But again, we've learned from everything that was given to us. The next question was, have patients expressed concerns regarding long-term follow-up? And again, free text was allowed. Data abstractor does not have patient contact. Other medical conditions taking priority, such as cancer. Unknown. Some are simply lost to follow-up. Again, we did see a lot of financial reasons, which was actually a selection. So, they could have just selected that. Not sure of patient's refusal, but we do have no-shows. We offer telemedicine for people leery of COVID. They asked for us to keep long-term follow-up mandatory, and they actually created a scorecard to show the long-term follow-up data that is presented at their vascular PI meeting. There's nothing documented in the chart about concerns. And again, I don't know, I'm not at the clinic scheduling end. So again, we've learned, from that question. And then the final question, do you review your long-term follow-up rates with your physicians and/or administrators? Again, what we took away from this question is a lot of what I call newbies, or those newer to data abstraction, actually responded to this survey, because as you can see, I have not met this time frame for long-term follow-up, insufficient participation time. We haven't had our first rate yet. Just started registry in July, but also we also found that some say, well, the physician can see the report on their own, or we review it annually, we review it periodically, nurse practitioners review it. So again, there were just a variety of answers that, again, we can take away and learn from. So a lot of people have asked, why did you do this survey? And the reason why we did this survey is following all of the fall regional meetings, there were different regions that were struggling a little bit with long-term follow-up, and we're just trying to learn how to improve, or, was there one specific, I apologize, that was Elvis, my French bulldog barking, I do apologize. But was there one specific variant or obstacle or something that was affecting all the regions? And what we've learned from this is that there is not one specific resource that's affecting all the regions. There is not one specific obstacle. As you can see, it's a handful, And as we all know, we want to blame COVID on everything, and COVID isn't the main thing. So, you know, so where do we go from there? What we've learned with COVID is that it actually has affected the regions at different times because, you know, it goes in waves. And so it has been interesting to do this long-term follow-up survey, just to, you know, again, to see the responses and learn how to move forward from this. So that was the reason why to do this survey in the beginning. And some regions have done their own survey within their own region, but this was just kind of a start, just to see where we were, what we were doing, and just to, you know, start a conversation, like where do we go from here? How can we improve, and how can we network and come together, you know, to improve all of our long-term follow-up. So just wanted to share with you, in April, we're going to have guest speakers, and many of you know these two beautiful ladies. So Priya and Rosha from the Baylor Scott and White Health System. They were our 2021 poster winners. They won for the VQI member favorite poster, and their topic was the VQI summary report tool in Epic. And they're actually going to be sharing their information on the VQI summary report tool in Epic in April. And they are an excellent resource for all. So they will, again, they will be making an appearance in April and sharing their knowledge on Epic and the reporting tool. So now we are going to do our Q&A, and just want to remind you our call for abstracts again for our VQI at VAM, June 14th and 15th of this year in Boston. And our next meeting is April 27th, 1 to 2 p.m. And again, don't forget to make sure that you mark it on your calendar, and Priya and Rosha will be our guest speakers. So we'll open it up to everybody if you have any questions.
Yeah, I got a quick question for you. So thank you for sharing the polling info, or the poll information. That is extremely useful. As you mentioned, there's a call for abstracts, and we're preparing an abstract related to COVID-19. So one of the things I would like to ask is this information going to be shared in some sort of report or something that we can use as a reference?
Oh, sure, absolutely. So just today, I wrote up an entire report that's going to go on our newsletter, and it'll actually show all of the graphs and everything. And but it'll just show like the top 3 for each graph. And it's actually going to house a link for those that weren't able to take the survey. So it's actually going to be an ongoing survey, so I can monitor it and then grab those answers, and then it'll kind of just be ongoing, so I can monitor and hopefully, you know, find a trend or something for that. The only thing is I am taking out the question that I said that we, you know, we had misworded. It was just misguided. It was just worded poorly, honestly, about the registries. So, so yeah, so it will be on vqi.org. I just wrote it up today, so I am having it vetted and getting it blessed by the other PSO staff. And once all of that has been passed through and approved by everyone, it'll be on the VQI website.
And hopefully published before February 18th, right?
Yes, it will be.
Thank you.
You're welcome. Let's see. Let's see, we do have a question, and I do have Carolyn here. She's with me. She's the other SVS PSO staff.
So the question is, we have a person that's newer to VQI, the abstract for carotid stents, and they're trying to figure out how the reports are used. There seem to be so many. So we have two main reports that are populated for all centers in all regions. And we have our first set of reports, which are our quarterly dashboard reports, and they will report on every registry that each center is participating in, and report out such things as not only outcome measures, but process measures. Outcome measures meaning complications, or process measures, getting a patient discharged within 1 to 2 days of the procedure, or documentation of the EVAR sac size, documentation of dual antiplatelet therapy. So, and then there's another resource that there are a number of training webinars that occur over the year, and it is provided by the 5OS Health team. They allow you or train you on how to use what is called the analytics engine, and within the analytics engine, you are able to create reports on your own. If your physician group has a particular area of concern, you can create your own reports and be able to provide it back to the groups. So we have 3 different types of reports. A lot of times there's networking within each center, and to get ideas of what the group might want reported out the following year, or the following meeting, excuse me. So those are just some ideas. As far as a plan to allow us to query 30-day and long-term follow-up data elements, we 5OS has rolled out a carotid and a endarterectomy long-term follow-up report. The next report that is due to come out after we get done with our quality checks is our PVI report, with the TVAR, EVAR reports to follow that. Long-term follow-up data elements are coming. We're just want to make sure that before we roll them out, we want to make sure that we've done our due diligence to make sure that things are in check. As far as 30-day, we're in discussions. We want to find out, I don't want to talk too much about this, but probably within the fall, there's going to be some discussions amongst all centers to see if 30-day rates, follow-up rates would be helpful to centers, because it is voluntary. Long-term follow-up is mandatory, but 30-day follow-up is voluntary. But one thing that is really important to find out is the rate of readmission within that 30-day window. So we're going to be doing some surveys. We're going to be talking to regions to find out if this is meaningful. So to be able to query your own reports, yes, that would be able to be done through the analytics engine, and you can create your own reports and do your own queries.
Thank you so much, Carolyn. That is so helpful. I apologize to whomever was discussing about doing your own poster abstract. If you need some data on what I presented earlier so you can get going, just email me and I'll be happy to work with you so you don't have to wait too long.
And just continuation, you are correct. The analytics engine does not allow you, is not available for follow-up at this time, but the 5OS team is actively working on expanding their capabilities and customizations for you and for all centers. One thing I can tell you, within the long-term follow-ups that are in production right now, there is drill down capabilities so that you will be able to see, and it's not just on those specific measures, but there are a number of different variables within each reporting measure, so that you'll be able to draw some conclusions on your own. But we do have work going on in the background, but we're just not ready to release it at this time.
And Carolyn, I just wanted to make sure, this was actually brought up last week. So if a patient has a procedure and then they come in for a follow-up, the patient can be seen by a different physician for their follow-up and it still be counted, correct?
It still would be counted as long as your physician groups agree to that. So what we have found, PSO says yes, it is a follow-up is a follow-up is a follow-up. Now, if the patient had, and I'm making this up, a carotid endarterectomy, and they go back to their primary care and the follow-up is focused on their gallbladder coming out and there's no mention of any outcomes from the carotid, that's, we hope that the follow-up would have some mention of the procedure that was done.
Absolutely. Thank you.
Thanks for clarifying that, but I actually emailed the pathway support regarding the long-term follow-up if it needs to be, related to the procedure itself. And the answer I got in written also is absolutely. So just be careful. We want to make sure that everyone is on the same page.
If I didn't answer that correctly, I believe that's what I was trying to say.
Yeah.
I apologize. I gave the scenario if a patient had an endarterectomy, but they're following up for a gallbladder removal, that's not appropriate.
Okay. And that actually makes sense because what we're trying to do, the main reason why we're doing follow-up is to make sure that, the graph is still in place and they're actually following up on the specific surgical procedure that they did. And the patients, here and there, they're doing their imaging related to the leg, for example, for PVI. So, okay, I think that needs to be clarified because I've asked a couple of regional teams as well as pathways. I think they've been saying any follow-up is acceptable because of the fact that medications are being asked. And then we just say no to not measured or not imaged for all the rest that are specific to the surgical procedure itself, like ABI, TBI, for example. We just say no, not measured. But it was still a follow-up. So and some of these patients, they go, different state kind of thing. But so they have a follow-up, but they don't even talk about the VQI case itself. So again, I think we are not all on the same page on this. And I do believe that your answer is correct, that it should be mentioned or the diagnosis should, the diagnosis should be mentioned or the initial surgical VQI procedure should be mentioned and that the follow-up is related to that. I think that's strongly we need to tell people because I don't think people who are having 100% long-term follow-up are actually not, sad to say, they're not because they're up there, not because they are doing it correctly. So just, I don't know.
This will be a point that we can emphasize during our spring and fall regional meetings. I don't want to make a blanket statement saying that everybody that has 100%, because I do know centers, some may have 100%.
Oh no, I'm saying higher performance.
No,
it's because they were able to do a follow-up. Yeah,
absolutely.
So I think moving forward, we need to have the same messaging. I mean, it's okay, we're doing what we can do, but I think okay. Thanks a lot.
And we will add that into our slides for our spring regional meeting. Just to call it out and say.
Oh, sure. And I think it might also help, just so it's not in meetings and some people miss it. Maybe the help text would also help clarify that, or the data dictionary that we receive, that the definition of long-term follow-up is such and such. I think that would really help everyone.
Okay, we'll take that into consideration. Thank you.
Thank you.
All right. Any other questions or anything? I can tell you we're already starting off 2022 very strong. I think I have 5 charters so far. So great work already. And are there any topics that you would like to hear later in the year? I know we had Lillian in October, and then we'll have Priya and Rosha in April. If you don't feel comfortable talking, you can just type it in the chat too.
Someone who could explain the carotid artery stenting would be great. You know how when they say predilate lesion versus predilate the protection device, I think there's deeper reasons why we do such thing, and I just don't see that clarified as much. You know, so I mean, if that is convenient for everyone, I think carotid arteries stenting. You know, if there's a person who could present, that would be great. That's all.
Hi, this is Eileen from Wake Med in Raleigh. I had a question with regards to carotid artery stenting. We participated in the NCDR PVI registry as well as VQI registry for carotid artery stenting. The NCDR PVI carotid artery stenting had a lot more data, definitions, and measures. So I was wondering if there are any thoughts or talks about adding more data elements to the carotid artery stent registry. Thank you.
So hi, Eileen, this is Carolyn Morgan, and Betsy, I apologize, I'm jumping in here.
No, you're fine. Thank you.
The carotid stent, well, here's the funny thing. Betsy and I were both involved with the NCDR carotid module when we worked at ACC. So that's just a little side note. But for VQI, the carotid registry was last revised in 2016. And we have NCDR representation on all of our committees. And so with that being said, when the carotid registry is up for revision, we will definitely be, I'm sure, expanding. But you know, it's that balance. You want to try and be parsimonious. I don't want to add, we don't want to add so much to the carotid registry to make it onerous, but make it meaningful. So we will be including, and I'm sure expanding upon it, as well as expanding our reporting measures. So that's a very, very good point, and thank you. As far as the question about hemo access, I think that is a question that we should send off to Pathways Support. The difference between your efferent and afferent artery and vein. If you wouldn't mind sending that off to our Pathways Support team, they'll be glad to get back to you.
Any other questions?
So there's a question about modified Rankin. Again, a little bit more clarity to your question, and send that off to Pathways Support, and they will get back to you with an answer as best they can. And if they can't answer it appropriately, or they don't feel like they're comfortable answering it, they will send it off to the proper team for a more detailed explanation. As far as the possibility of adding an option for not documented or other, that is always, that's a sticky one too, because as we try to watch for data outliers, meaning maybe someone consistently answers other or not documented 100% of the time. So the reason would be whenever possible, that we would encourage people to answer. But yes, we are beginning to expand upon not documented or other for most data points. I'm not going to say every data point, but I'm going to say most data points. And like you said, depending on the data point. Just remember, I know it's not, you guys all work so hard and make every effort to answer every question, but just because you submit without validation is not a bad thing. It just means that you're not going to make up an answer just to make sure that you get every data point answered, and you don't know the answer. There was nothing provided. And so whenever you have to leave a data variable blank, when I was a data abstractor, there were times I had to leave them blank. And I just would leave myself a little note in the comments box so that if there was ever a question, I could go back and say, well, it wasn't applicable, or this is the reason why.
That's a good point, Carolyn. Thank you.
So when we're talking about our CCA, ICA, EDVs, there has been a goal for not only SVS VQI, but ACC NCDR to harmonize data points, harmonize common data elements across all registries, and harmonize common data elements across like registries. So the common and internal carotid EDVs are harmonized across both your carotid artery stent registry and your endarterectomy registry in alignment with the vascular ultrasound registry. So those are 3 like registries, and the data elements are harmonized across the 3 like registries. The remaining number of opioid pills is no longer a mandatory field in your long-term follow-up. So you will be able to submit with validation if you leave that blank and get long-term follow-up credit.
Oh, nice. Very nice. Getting a lot of kudos there, Carolyn.
Yeah. No, that's a great question. If you submit without validation, the procedure does not fall out of the outcomes. So for instance, I'm annoyingly, I give examples to a fault, but let's say that you're doing an EVAR data abstraction and you leave the zip code out. There are certain variables that you will see on your spring and on your spring and fall reports that have risk adjustment in them. It says with a little asterisk, how many of these procedures were complete and how many were not complete. The way that the complete and not complete are calculated are the variables that are part of the risk adjusted calculation. So in this particular example, if you left the zip code blank, you would still be included in the EVAR registry reporting measures. And if you have additional questions on that, I really encourage you to, again, submit your question through Pathways Support, and then they will forward that question over to the data analyst, and they will get back to you and give you more detail. And yes, we are going to be doing more and more cloning. So I am in the process now of finishing up our infrainguinal registry revisions. with that revision, you're going to be happy to know that there is a help text for 99.9% of every select option, and there will be cloning capabilities. The cloning will also be part of the superinguinal that is coming as soon as infra is done, as well as Open AAA, which will be to follow our superinguinal revisions. So as we start our revisions on down the line, with each revision, cloning will be added.
I think you're getting some high fives there, Carolyn.
I was a data abstractor. I agree. But thank you, everybody.
All right, anything else?
I will encourage you, because this is the first time we've done long-term follow-up. It's not actually VQI that's doing the long-term follow-up reports. It's the Pathways/5Os team. As you have ideas for future enhancements for the long-term follow-up reports, it would be good for you to submit those just to Pathways, and then they will have a running log. So with the next revisions that come down the road for those reports, since this is our first release, we'll have some substantive data to say, hey, this was a recommendation by a number of people, and we think that it would be a good idea.
That's a nice suggestion too.
So let me see who asked this question. We're talking about people changing between different electronic medical records. They changed from, Terry had changed from Paragon to Cerner, and her medical record numbers are different. So keep in mind that whenever you, and I'm going to pull this up just to make sure I have the right terminology here, are in your user interface, you can enter your medical record number to associate it with the patient, but we also have our record ID that is assigned by, I believe it's assigned by the 5Os team. So as soon as you start entering a record ID, there is no way for us to help you match those up unless you would try to do a match by date of birth or by patient name. Does anybody else have any ideas? Has anyone else gone through this same process and can share with Kelly or Terry and how you were able to work through this? The social is a good idea, but the problem is some people don't put the actual social in. They put in a fictitious social number or MBI number.
The social security number, that's what you mean. So the social security
The PROC ID, yeah.
depends on what the facilities, private officers agreement. Some of the hospital had a very strict policy. They are not allowed to enter any social security number. So that will be all the 9 to enter that in pathway. But sometimes for the so that definitely is the leader physician needed to talk to the privacy officer, see if there any agreement could be set up before you can go further. That's what I would recommend. A lot of facility only allow the last 4 digit in password.
Mm-hmm. Yes.
Oh, that's nice. Universal ID given for all facilities.
That would be great.
Yeah.
Even at the health system, Betsy and I go back even before ACC NCDR, we worked for the same health system for years and didn't even know each other. And even within the same health systems, we had this. Betsy, did they have the same medical record number? I believe. No,
Yeah.
they do. They do.
Mm-hmm.
It is helpful.
Hmm. Well, that was a good question.
I have to be honest with you, Eileen, because of the TVAR dissection project, there are going to be very little changes made to the TVAR registry until the dissection project is completed. So I apologize, but I'm just trying to be transparent. We're kind of bound right now, especially with the ISS severity code. I'm sure that's part of the dissection project. So that I feel confident won't be going away until the dissection project is done, if it goes away at all.
For those of us abstracting for multiple facilities associated with a health network, and our patients are scattered between 6 different campuses, is there any talk of us being able to query all of our patients at the same time? Because it's been very time consuming and tedious having to run 9 different queries in 6 different facilities. Well, not 9, but some of our campuses only have like 3 or 4 registries, but you're having to do this same thing over and over again.
You're a mind reader. We are working on system reports so that you'll be able to get all your patients within your system.
Thank you.
You're so welcome. Again, it's going to be a bit till we get them into production, but we are working on them.
So is that will be auto report, or we gonna pull by ourselves to set up like a time frame that we?
I unfortunately don't have any more details aside from there. I know that for a fact that there are conversations about system reports being developed for the very same reason that Catherine and you were talking about. As we know more, we'll be glad to share with you, but I just don't have any details right now. I apologize.
No problem. Actually, it's good news for us. I kind of happy to hear that.
Sometimes things just don't happen fast enough, unfortunately.
I'm looking forward to that.
Oh, good. You guys are so kind in thanking me for answering the questions, but Betsy and I were in your shoes and not very long ago. So we know, and we want to support you the very best that we can. And Betsy, again, I apologize for monopolizing your meeting. I'm sorry.
You are not at all. We're a team. That's why you're invited too.
Okay.
All right. Well, if that's everything, we'll give everybody 10 minutes back for your day then. And we look forward to seeing everyone in April. And we hope you'll join us for our guest speakers, Priya and Rosha. And get those abstracts out if you don't mind. We'd love to see them, and we'd love to see everyone in Boston in June 14th and 15th. I can't believe that. So anyway, it'll be here before you know it. So thank you so much. And if you have any questions, suggestions, or anything, don't hesitate to reach out to us. So take care, everybody, and Happy New Year.
Thank you.
Thanks, Yuming.